Hello, I'm Dr. Alvin Wells. I'm a board-certified rheumatologist, and I practice out of the Rheumatology and Immunotherapy Center in Oak Creek, Wisconsin. I have been doing ultrasound in my clinical practice for the last 5 years. My goal in this DVD series is to give you an introduction to the use of ultrasound in medicine, to show you some clinical illustrations, and to show you how you can apply this to your clinical practice. So whether you're an orthopedic surgeon, a sports medicine physician, or rheumatologist, or general practitioner, my goal is for you to have a tool that you can use to increase your skills, something that you can refer to update your skills and to help you increase your clinical practice. I hope you enjoy the series. In this part of the DVD series, I will introduce you and review some of the musculoskeletal anatomy. I will give you an introduction about the use of ultrasound in medicine, some of the principles of how ultrasound can be applied to looking at clinical illustrations. Key to understanding ultrasound is actually knowing the terminology, and that I will review with you as well. I will show you some specific illustrations for rheumatology and a number of different clinical illustrations. Ultrasound has been around for decades. Most of the technology began in Europe, and some of that evolved around the Second World War. It actually was the Europeans who revolutionized the use of ultrasound, not only in general physics, but also in medicine. One of the godfathers of ultrasound is Professor Ian Donnell in Glasgow, who actually showed that you can actually use ultrasound for a number of different clinical entities in medicine. The first publication of the use of ultrasound in medicine was in Lancet in 1958. And in this figure, actually, you can see Dr. Donnell and one of his assistants showing the first ultrasound machine that was there. I want to show you how large this machine was. In this particular study, they actually used ultrasound to look for abdominal masses. Let's fast forward to over the decades. Here you're seeing going from these larger machines on the right to some of the smaller machines. And this is where we are with ultrasound technology in 2008. There are a number of different equipments that are available, and I'll showcase some of the equipment that we use in our clinical practice. Ultrasound technology involves pattern recognition. And if I show you some patterns that some of you might be familiar with, you're actually, for example, in this image, able to identify two different structures. On the left part here, you see a young lady, but if you look at the structure in closer detail, you actually can identify a second image, an image of an older figure that you can see on the right side here. Another similar type of image is seen here. Most of you will see that this is some scenery from the outside. But a closer view will see that indeed there is not just a couple, a lake, and some trees, but you actually will see the structure and the outline of an infant. And this is what ultrasound involves. Many of you are familiar with other more common patterns. If I were to show you a typical X-ray of the hand, many of you would recognize that. So the key to mastering ultrasound is actually learning the pattern recognition, practicing, and repetition. The principles of ultrasounds are easy. You essentially have an ultrasound wave that is generated through a transducer, which many of us refer to as a probe. That ultrasound wave then targets a structure. In this case, we're going to be looking at structures in the body. The ultrasound signal then hits that structure and then is sent back to the transducer, and then the computer technology of the machine translates that into an image that we will see on the screen. And as you see in this image on the right, it is key that the transducer is held at all times perpendicular to the structure of interest. Because if you see here on the left, if this ultrasound waves are reflected back at an angle less than 90 degrees, then you will get a black image, and I'll show you that. That is a term that we call anisotropy. Ultrasound terminology is key. There are essentially three different colors that we look at: black, gray, and white. Black structures in the body which reflect fluid, for example, blood or effusions, or cartilage, these are termed anechoic. The grayer structures in the body, things like the synovium, these are referred to as hypoechoic, meaning low echo signal. The white structures of the bodies, the one that have high reflective signal, are hyperechoic, and these represent the bone, the tendons, the nerves, and calcifications. And indeed, it's just not that simple. It's not black and white. It actually is a gradation. So when you're going from an anechoic to a hypoechoic to a hyperechoic signal. And actually on the images that you will obtain, you will see all of these different colors and degradations thereof and variations thereof. For example, here is a structure looking at going from the subcutaneous structures superficially, looking at a pattern that we see in a nerve, the hyperechoic signal. We see a muscle, and then we see some tendons. And I will show you all of these things in details. But again, going from anechoic, hypoechoic, and hyperechoic. And this is a structure, another pattern that you will see. For example, if I look at one of the small joints of the hands, like the proximal interphalangeal joint, I can see the skin structure here, I can see the flexor tendon, and then I can see the outline of the proximal interphalangeal phalanx, the articular cartilage, and the small amount of synovium here. Again, the purpose of these figures are to give you some familiarity with the terms and with some of the colors that you would see, going again from anechoic, which is going to be black, hypoechoic representing the synovium, or hyperechoic representing the bone. Another example of that is actually looking at the articular cartilage of the knee. Here we see the femoral condyles and a very, very nice structure showing the articular cartilage representing the bone. Other structures that you can see here, the muscles and the tendons around those and some of the perimuscular sheaths. And I'll show you some more clinical illustration of those as we move through the video. The other key for mastering ultrasound is actually knowing the orientation. By convention, ultrasound scans, when we present them, when we're doing our reports, and actually in the publications, the left side of the screen represents the proximal part of the body, and the right side represents the distal. For example, using the logic view system, you can actually see the metacarpal phalangeal joint on the left. Going distally, you see the proximal interphalangeal joint, and then most distal, you see the distal interphalangeal joint. So again, the left side of the screen is going to be proximal, the right side would be distal. This is when the transducer or the probe is held in a longitudinal orientation to the body. If we were to change that and go to a transverse, meaning turning the transducer 90 degrees, and I'll show you how to do that, we actually show that the left side of the image represents the medial portion of the body, and the right side represents the lateral. For example, in this image we see, looking at the region of the carpal tunnel, we see the median nerve right here in the center. Over to the right, we see the radial artery, and to the left, we see the flexor tendons. We will go through those in detail and show you how to identify those tendons. So again, when this transducer is held in a transverse orientation, the left side of the screen is medial and the right side is lateral. I always go to what I call the cucumber view because you want to obtain all of your images in two different orientations, and this gives you a more common representation of that. So if you were to slice a cucumber in longitudinal view, this is one of the images that you will obtain, and when you take that and do a transverse section or do more of a slice of that, you will see the type of image. This is the thing you need to get familiar with and actually doing for every image that you obtain on your patients. Here's an example of a patient who complains of some shoulder pain. You're actually looking at if they have any signs of bicipital tendonitis, is there effusions and things around that. So on the left side, we see a transverse view looking at the biceps tendon surrounded by a small amount of effusion sitting in the bicipital groove of the humeral head. When we rotate the transducer 90 degrees, you see that tendon then in a longitudinal pattern. So again, transverse and then longitudinal. One of the other key things is learning how to hold a probe. I always have to remind people that the probe is a fine, delicate tool. It's not like a Black & Decker drill. So you don't want to hold it like a vigorous tool like this. When you're holding it, you want to hold it like a fine tool. You want to make contact with the patient's skin because remember, you're going to have a transducer gel underneath the probe, and that sometimes can make it slippery to make contact with the patient's skin. And we'll show you that when we do some of the live demonstrations as well. The other key thing to ultrasound is knowing what I call the knobology. In other words, studying the knobs on your machines, learning how to use those. There are a number of ones that are common, and there's some others that are specific, and we'll talk about those that are unique to the Logic E. For example, of course, like all electronic equipment, there will be a power on and off switch, knowing where that is. Then also changing the gain. The gain essentially allows you to take the image going from a darker image to a more intense image or a whiter type of an image. When you're looking at superficial structures, you need to be, of course, superficial as far as your imaging, but when you want to go deeper, let's say if you're looking at the sacroiliac joint or looking at the femoral head, you want to go to a deeper level and being able to zoom in on structures as well, and I'll show you how to do that with the machine. The key thing is where you're putting the transducer on, you want to be able to get the maximal focus of your transducer or your ultrasound wave, and the focal points are going to be key as well. For example, if you're looking at the metacarpophalangeal joint, you would like to focus on the joint and not being deeper than that. But remember that the nice thing about ultrasound, you're able to do dynamic images. So being able to take a still picture that you can actually save to electronic medical record, that you can print out to give to a patient to take home, so the freeze button is going to be key for you as well. One of the key things also for ultrasound is looking at inflammatory diseases, which represents blood flow. We'll talk about that. So the Doppler signal is going to be key, and knowing where the Doppler button on the machines are as well. And then, of course, if you're looking at areas of measurements, for example, how much is an infusion, how large is the thickness of the median nerve, how long is a tendon, all those are different things we can look at. So learning how to obtain measurements and looking at other aerial structures, for example, of nerves and tendons are going to be key as well. And in some of the machines, like the Logic E, has other unique structures. For example, learning how to scan the entire length of the median nerve or scanning the entire length of the quadriceps tendon. And we'll show you using the Logic View technique that how you can easily capture those images. So let's go through some of the specific areas of anatomy that are going to be common to whatever practice, whether you're looking at rheumatology, musculoskeletal medicine, sports medicine, or orthopedic surgery. The first is, of course, as you put the transducer on the patient's body, you're going to look at the skin. The skin is described as being slightly hyperechoic, meaning it's going to be more white than other structures in the body. It is best visualized in two different ways, and I'll show you what we use in our clinic, something called a standoff pad that increases the surface area between the body and the transducer that gives you some better detail. Or you can take advantage of using some excess gel to make a better contact with the skin and give you more surface area. You also want to use a high-frequency probe when visualizing the skin. The Logic E has a system where you can go anywhere from 8 all the way up to 13 megahertz. So the higher the frequency, the better view that you get for superficial structures. So you at least want to have an equipment that is at least 12 megahertz that allows you to visualize the skin. So again, slightly hyperechoic, best visualized using excess gel, and best visualized using a high-frequency probe. And this actually shows you the thickness of the skin. One of the other nice things about rheumatology, there are certain disease conditions where one wants to look at measuring the thickness of the skin. For example, scleroderma and psoriasis, and we'll talk about that later. Going from the skin, we encounter the subcutaneous tissue or the fat. That also has a unique ultrasound pattern. The subcutaneous tissue is actually referred to as isoechoic. In other words, you look at the scan here, you essentially see the same type of pattern throughout the skin. Now that might be superimposed in there other types of areas where there might be more blood vessels and things. And also you will see that some of the fat has what we call hyperechoic septi. After the skin, the next area that you will encounter will be the subcutaneous tissue. The subcutaneous tissue is described as being isoechoic, that you can see here. It has a very, very unique pattern of being a similar type of echogenic signal throughout. Even though it is usually referred to as isoechoic, you can also see hyperechoic septi throughout this. And these are some of the whiter areas that you will see. Going from the skin, the next structures you will encounter will be the tendons and ligaments. The tendons and ligaments, remember, they are oriented by the collagen fibrils to give you structure and support. Actually, the nice thing about the ultrasound, you actually can get the detail of those tendon fibers. This actually shows an example of a flexor tendon of the hand showing the fibers that you see. It gives you what we call a fibrillar pattern, and again, that will be slightly hyperechoic. One of the nice things about the ultrasound is you can do a dynamic examination. If you don't know whether you're looking at a tendon versus a nerve, remember that the tendons will move, whereas the nerve and other structures will not, and we'll show you how to do that when we do the dynamic examination. Other structures that can be visualized on the ultrasound are actually areas where there's fluid. Remember that the bursa, which coat the areas so there won't be any irritation of tendons and ligaments, that in physiological view, they normally have no fluid in there. So in normal individuals, as shown here on the right, you will not see any fluid. It's only when patients are symptomatic where you actually will indeed see fluid. This is an example of a patient that had a supraspinatus bursitis. And actually one of the ways you can tell that it is a bursa, an inflammation, that you can actually compress that area and actually displace the fluid. Another example is seen here of a patient who had shoulder pain, significant tenderness right over the subacromial region, and you see this huge bursal area right over the humeral head and underneath the other tendons and ligaments around the deltoid muscle. So again, fluid was going to be anechoic. Is this blood? You can actually look at that and detect it, but one of the other nice things about this, you can easily remove that fluid under ultrasound or needle guidance. So how do we use ultrasound in the clinical arena? One of the nice things about ultrasound, it actually enhances your clinical evaluation. We all as clinicians have very good clinical skills, and we can be very good at making a diagnosis and doing intervention in our patients. Well, the sonography comes in between that, but because it allows us to improve our functional anatomy, it allows us to improve our examination skills, and allows us to improve our interventional skills, specifically when doing needle guidance. The other nice thing about the ultrasound is that it takes a static examination and turns it into a dynamic examination, so we can look for things and structures that move throughout the body. Let's use a common example of something that we would see in rheumatologists. So if you have a patient who has what they complain of a trigger finger, well, what portion of the flexor tendon actually is indeed triggering? So we actually can see that as we look at, again, going for a longitudinal scan of the hand. Here is the flexor tendon, and it's right in this area here. You can see that there's a snapping or a popping motion, and this is where there is some triggering. So if I want to do some needle guidance intervention, it would not be at this portion. I would want to do it in this area. So the nice thing about the ultrasound, which is different from MRI, that I can do this dynamic examination and actually then better target and treat my patients. There are some things that are appropriate for rheumatologists and other sports medicine physicians to do when thinking about how do we use ultrasound in clinical practice. These have been very, very nicely outlined for us by our European colleagues, and the reference is actually stated on the slide. So what things are appropriate for rheumatologists to do? Actually detecting inflammatory arthritis, looking at tendon pathology and for detecting effusions, looking for bursitis like I showed you in a clinical illustration, and then more specifically now, using it to monitor disease activity and monitor disease progression. And I'll show you some clinical examples of that. And then, of course, for using it for needle guidance, for aspiration, and for injection into various areas of the bodies. The Europeans have also told us there are some things that we don't think would be appropriate for us to do with ultrasound. For example, identifying degenerative arthritis like osteoarthritis. Of course, I can show that there's narrowing of the cartilage. Of course, I can show that there are osteophytes in the joints. But what would the ultrasound add to that above plain x-rays or other images? Looking for signs of muscle injuries, ligament injuries, or soft tissue masses, for example, like tumors, and nerve lesions. So these are some of the things that the Europeans have shown us over the years that are not appropriate for ultrasound technology. As you're looking at various equipments to add to your clinical practice, what are some of the things you need to think about, and what are some things that you might be able to add as an option? Well, first and foremost, you have to have the right tool. You have to have the right transducer. For example, in most practices, if you're going to look at more superficial structures, having a high-frequency transducer is going to be key. And again, by high frequency, we mean something that's at least 8 megahertz or above. The Logic E is predicted here, as I mentioned, is able to go from 8 megahertz all the way up to 13 megahertz. If people are going to be looking at structures that are deeper in the body, for example, the sacroiliac joint or the femoral head, you want to have a transducer that allows you to go to deeper structures, for example, 4 megahertz. The nice thing about the Logic E that one can actually have other transducers you can add to this that allows us to look at either the sacroiliac joint, looking at the lumbar spine, and looking at the femoral head. The key for actually for rheumatology and other areas where we're looking at inflammation is actually looking at blood flow. And this is where having the power Doppler and color Doppler comes in handy. So for things like synovial thickening, synovial inflammation, all of those areas is where the power and color Doppler are going to be key. Other things that might be optional depends on what your use is. For example, if you need to have a USB port to transport images from your ultrasound machine into an electronic record, having a printer. If you're still using paper charts, having printing out an image that can be incorporated into the clinical records. Video images if you're going to be doing it for lectures and things like that. And then, of course, what other features? Looking at whether you can do not only two-dimensional, which ultrasound is, but adding three-dimensional, and even now some of the newer machines, the four-dimensional ones. The nice thing about the Logic E equipment is that one can actually upgrade the software. So adding your three-dimensional programs. I talked about doing a full view using a technology called the Logic View, and actually adding a number of different transducers that allow you to do a number of different areas, whether superficial or deeper structures. This is an example of what I've done in my clinical practice. Here you see in the background the Logic E machine over a patient, and then we've also added to the ultrasound room a flat screen monitor that we can do. Particularly, it comes in handy when doing needle guidance for intervention, for example, of the sacroiliac joints or for the facet joints of the spine. I've been alluding to Doppler and what is Doppler and how do we use that in clinical ultrasonography. Well, remember the Doppler effect we all learned about in physics? To make it simple, you know, when an ambulance is moving toward you, the sound gets louder, but once the ambulance is past you, that sound drops. And this is what Christian Doppler talked about. So the Doppler effect looks at a shift in sound waves, and that shift in the body for sound waves is looking for things that move, and those things that move most is going to be the red blood cells. It picks up color. We can show that looking at direction and velocity. Many cardiovascular physicians who are looking at images, looking at whether a blood vessel is a vein or an artery, blue versus red. But also you want to look at power. That actually tells us, is there some intensity, is there flow here or not? It doesn't give us a direction. It actually tells us it's whether something is there or not. So these are low blood flow states like we see in the synovium of a patient with inflammatory arthritis, and that's going to be really key for rheumatology and for sports medicine physicians. And actually an ideal situation is to have the combination. So not only looking at color, but also looking at the power Doppler that gives us the best of both worlds. So here's a patient, for example, had a swollen wrist. This would not be hard for any of us to miss or to make the diagnosis, but actually what is it and what's going on underneath that wrist? And if we take a look at that, you see again here the skin, you see the joint, and then you also see all this increased blood flow over the surface of that joint that represents all the inflammation and the thickened synovium. We actually can measure the thickness of that synovium and actually can remove the fluid that we see here represented by this hypoechoic or anechoic pocket. And here's another example again. Here you see some effusion underneath the skin. Here you see some thickening of the synovium over the bones of the wrist. Let's talk a little bit about how do we use ultrasound for needle guidance and for what we call an interventional ultrasound. Interventional ultrasound, I think, should be used first line. Not only first line, but also when conventional approaches have failed. For example, in patients who are afraid of needles, like pediatric patients. Ultrasound is very good for doing needle guidance for targeting small and medium joints. For example, looking at the metatarsal joint or the first MTP in patients with gout. Identifying soft tissue structures. I've shown you, for example, how you can identify the median nerve, looking at fluids around the synovium. And also for avoiding patients who are on blood thinners, for example, making sure you're not going to enter into a blood vessel or injure a nerve. For needle guidance for performing arthrocentesis for a number of different conditions, whether treating crystal-induced arthritis or other types of inflammatory arthritis, or for identifying pockets of fluid. For example, if a patient has a swollen knee, is that fluid indeed in the joint of the knee, or is it in one of the many bursa surrounding the knee? So needle guidance is also key for delivering viscosupplementation and the number of viscosupplements that are used for patients with osteoarthritis of the knees. We also can use needle guidance with the ultrasound for delivering depositions of steroids, whether into the biceps tendon or into the acromioclavicular joint of the shoulder. Future indications, we will see that the needle guidance using the ultrasound will be used for a number of different things. Again, these haven't been approved yet, but potential for looking at for needle guidance for releasing of the carpal tunnel, needle guidance for using something called tenotomy, and other technologies. So here's an example of showing, again, not an actual patient, but actually showing what the approach will be. So you see how we hold the transducer in one hand and how we have this to look at the needle to direct the fluid into the subcutaneous and actually into the knee joint in this particular patient. And finally, you can actually use the ultrasound to identify deeper structures in the body. Let's take, for example, if a patient has osteoarthritis of the hip. You actually can not only tell that there is some narrowing of the joint space of that hip, but actually can use the ultrasound to tell me how far down do I need to be. We can see here that around 2 or 2.5 centimeters in that we will get a deposition of steroid into the femoral capsule. So there's no more guesswork. There's no need to send patients for doing more interventional things like fluoroscopy. This is something that can be performed in the clinic. So overall, I think ultrasound has really made an exciting enhancement to our clinical and diagnostic skills, whether you're a rheumatologist, someone involved in sports medicine, or orthopedic surgery. The data to support the use of ultrasound for diagnostic and interventional modality is actually growing. It's actually standard of care in Europe, and actually in many sites and throughout the United States, it is becoming a standard of care, for example, delivering viscosupplementation into areas other than the knee. There is a significant learning curve, and we're hopeful that this DVD will help make some advances to that.